contact with us to let us know that they are having numerous issues, from just having codes submitted by an ICD-10 code, to having claims reimbursed in full, with regards to PMB benefits on a annual basis. And obviously every year these schemes come with a new funding criteria or new funding guidelines. And then just as you kind of have gotten into it, the new year comes, January comes, and you're back to square one, where you're having to learn the whole process again. For patients obviously impacted by rare diseases, this is a significant cost burden. We did a poll a couple of months ago, which Anissa will give you some clarity on. But we do realize that a lot of patients are paying in a significant amount every month on shortfalls, etc. And we know that a lot of the times that it's an administrative error, and that administrative error is not really picked up by anyone. So you are sitting with patients who are none the wiser. Doctors' rooms are often not using correct ICD-10 codes, etc. Patients aren't aware of the fact that they need to give ICD-10 codes a lot of the time. So you'll, as an example, you'll be referred to go for a scan for something, and then it gets submitted and it doesn't get paid correctly out of PMB. So all of these things end up being quite significant challenges. And I always say, as a mom of a rare disease patient, I think the frustration for me isn't always dealing with the condition itself. It's dealing with all the associated admin that goes along with it, the doctor's appointments, the keeping track of the claims, making sure that you've got to all the therapy sessions and stuff. So this is one area where we felt we could really just improve the services that we offer. So Anissa and Jerome, who are joining us tonight, they have some extensive experience in terms of dealing with medical aids, and they were introduced to us by one of our support groups, Melissa Platt from Raising Footprints for Sam, and then also from one of our doctors who is a palliative care specialist. And they'd both made use of the service before and were aware of the challenges. So we wanted to bring it into as a service that we could offer to our members, and we're really hoping that we can take it from strength to strength. Having said that, please do understand before we allow Anissa to speak that there might be some teething issues in the initial phase of this program, not so much to the service that's offered, I think more significantly around the rollout. But please do just bear with us as we get off our feet. This is the first time that we're going to be doing it in such a formal capacity. We have set up our database to be able to allow you to have reference numbers, calls, notes, etc., everything added onto your profile. So we do provide that. We do foresee that you will have enough information and that you will get communicated with on a regular basis. So we're hoping that we can really, really go on and help our patients get what it is that they need, so that they can stress less about the bills and the financial claims, and they can focus more on what needs to be done in terms of being healthy. So having said all of that, I now introduce you to Anissa Ali, who will give us a little bit more detail. Thanks, Anissa.
Thanks, Kelly. Thank you so much for that really insightful introduction. I think you've alluded to a lot of interesting points that Jerome and I will pick up in our presentation. Before we continue, is there any chance that Jerome can be picked up on the screen as well? Because he'll be going through some of the presentation too.
Okay, there we go. I have asked him to change to video.
Okay, cool. I'll just continue in the meantime. So thank you for affording us the opportunity to present to your community this evening. And I think it's just probably worthwhile to share a bit of our journey so that you get a better understanding, your community gets a better understanding of how we found ourselves partnering with rare diseases and taking our services forward with you. Sorry, let me just share my screen. So, Kelly, you rightly mentioned that we were referred to you by one of your doctors, and that's Dr. Minaz Ali. And she actually started out as my children's GP, and over time we struck up a good friendship, and we found ourselves having Thursday afternoon tea. And during these tea sessions, we would talk about everything, and we would often get back to work and the challenges that she faces in her everyday. And the more she spoke about this area of work, which I then got to learn was palliative care, and particularly with a focus on the pediatric population, it piqued my interest. And, you know, it was just through these conversations that I understood that patients with rare diseases, as well as their families, are presented with such a unique set of challenges. I think from the time symptoms start, right through the diagnosis process, and then living on with the condition. And well, you know, there are a lot of obstacles that these families face. And I mean, learning from you guys, it's a matter of symptoms being all over the show, and they're not cookie cutter, so to speak. So it's not, well, you present with A, B, and C, so you should have 3. But it's a tumultuous amount of tests that have to go, that the patients have to go through. And this often delays diagnosis being made. And even then too, when diagnoses are made, there are very few providers, healthcare providers, who understand the condition, who can share enough information. And then, well, now you know what you've got, but sorry, there's no drugs available for it. So it's almost like stumbling blocks at every aspect of the process. And we find that with the lack of there being pharmaceutical treatment options, the only alternative then is for symptomatic treatments. So it becomes a very long learning process for individuals and their families alike, because you go through this entire process of not knowing what's wrong with you. And then, of course, you learn what's wrong with you, and then it's understanding what triggers are. It's understanding how to get you into a better space, or understanding what disease progression presents as, and then what the following steps are. So I guess no 2 days for a family are the same. And so when you start understanding it at that level, you can understand why families are just feel like they're taking a knock in every aspect. Psychologically, they are just battered and bruised, physically exhausted, emotionally in tatters. And then, of course, there's that element of the financial burden. And, you know, it just becomes a very, very frustrating process for families. So we thought it's worthwhile sharing just 2 experiences that we've encountered with families who have had a family member with rare diseases, and, you know, just to share with you how we managed to get them sorted out. And for us, it was almost second nature, whereas for them, it created massive frustration. So the very first patient we were introduced to was a 7-year-old female, and she presented with a very rare form of a congenital heart defect. And 2018 proved to be a particularly hard year for them. And she was hospitalized a number of times in 2018. We met them in their last hospitalization towards the end of 2018. And the first thing that we learned was that they were highly frustrated because there was a bill dating back to an admission that had happened in January of 2018 that still wasn't resolved. And the dad had a lot of back and forth with the medical aid, and there just was no resolution. And we took it upon ourselves to understand what was happening. And it actually turned out to be something as simple as the medical aid, not updating the length of stay. And because of that, they weren't paying the hospital, and the hospital kept bouncing it back to the family. And the family kept saying, but the child was in hospital for the duration of that time. Why am I liable for this account? But it also turned out at that very point, the medical aid was going through some major revamps. And so there was no continuation in communicating with this patient. So somewhere calls were logged, but no one was getting back to the family. So us having intervened and getting this sorted out meant that the family no longer faced this bill of tens of thousands of rands. And again, it's something that was, it shouldn't have happened, but it got to a point where the dad was, I just have to settle this account. And in further discussions with them, we knew that we could assist from a PMB perspective because her condition presented with PMB level of care. And we kept speaking to the family, and the dad kept saying, but I've got PMB cover, I've got PMB cover. And eventually when we unpacked it, he was confusing PMB with chronics. So, you know, it's even when members are confident that they understand their benefits, they actually don't really understand it. The next case is one that Jerome was a lot closer to, so I'll let him take you through that. Jerome, I can't hear you. Okay, I'll continue then until he comes right. So the next patient was a 16-year-old female, and she was diagnosed with leukemia. The family, obviously, it was a big thing, hit them from all angles, and they weren't certain where to from there. And obviously, their main concern was getting their child better. But obviously, with that comes massive costs, and they just didn't know where to. So we then had to understand from the medical scheme that they were on, what oncology programs they have and what their oncology benefit is, and get the member registered on that benefit. We then retrospectively reviewed all claims that happened during the diagnostic time, and those were then resubmitted to be reprocessed and paid from the correct benefit, which was the oncology benefit. We also did a lot of follow-ups to ensure that the treatment plans were updated and delivered to the medical aid timeously, and then obviously confirmed that the benefits were received. And it was just a matter of sitting down with the family and making them understand what the benefit is and what they have access to, and how to ensure that every time a claim is submitted, what needs to be present on that claim in order for it to pay from the oncology benefit. So it was really, unmuddling what was confusing the family, on top of having to deal with their daughter, who is now faced with this life-threatening condition. So in addition to all the families that we've met where we have managed to assist them in this regard, we were also introduced to a mum who had gone through this process. And I would never even begin to describe what she's gone through, because I don't think anybody could understand it. But she had lost her only child to a rare disease, and she had gone through exactly what I described in the first slide of diagnosis not being made on time, the treatments not being conducive to the condition that her child presented with. And unfortunately, he had passed away. But she turned it into something so positive. And Melissa Platt had then founded the foundation called Footprints for Sam. And Footprints for Sam stand for a lot. And I think the one thing that it stands out for me personally is the advocacy in caring for patients with rare diseases, and particularly children. And so obviously Sam's legacy lives on through the foundation. And that's essentially how we got onto rare diseases. So we had met with Melissa and tried to understand how we could be of assistance with our level of expertise. And Melissa then introduced us to Rare Diseases South Africa. And when we did a quick Google search on it, the very first strategic key objective stood out for us, and that was patient navigation. And that's exactly where we saw ourselves fitting in, because that is how we have marketed ourselves in navigating healthcare to allow members access to better funds. So we are a patient-focused company, and we assist members of the public navigate their healthcare insurance. And this is with the intention of optimizing access to care and funds. And so our skills lie in claim submissions and adjudication. So that's just ensuring that the claim meets all the tick boxes, and when it gets sent to the medical aid, follow-ups are done to ensure that the claims are paid in full. And then medical administration is just, it's one word encompassing a lot. So we do benefit applications, benefit updates and renewals. We have expertise in putting together cases for submission to for PMB funding. And this is how, we met with Kelly from Rare Diseases, and it just happened to be at the right time when Rare Diseases were putting the spotlight on case management and wanting to ramp up their services. So we agreed that there was great synergy, and we really, really are proud to be a partner of Rare Diseases South Africa. I think it's very important that we make it clear at this point that we're not a brokerage service. So we in no ways are affiliated to any one medical scheme. We do not advocate for one medical scheme. We don't sell plans. We don't advise on plans. We understand what plan you are currently on, and we then assist in navigating your benefits optimally. Is Jerome still not online? Okay. So I think it was worth just talking through the private healthcare insurance and go through some of the ups and the downs. And insurance, healthcare insurance, like any insurance, is to prevent you from that catastrophic event, having to outlay massive amounts of cash. So it does protect against unexpected high medical costs, but it also allows members with private healthcare insurance to access private medical services rather than relying on the public sector. And certain schemes allow for day-to-day cover. So you have access to optometry, to dentistry, to getting some drugs, prescription drugs, visiting the pharmacies, etc. So how medical aid works is a member pays a premium, and the premium then goes into a pool of funds. And that pool is then managed by an administrator. So the administrator then segregates the funds into the relevant benefits that it should go into. And that then becomes the benefit that you have access to. So your doctor, hospital bills, etc., will pay from one pool of the benefits, and then you have your medical savings, which is something that you need to manage yourself. But that also does still come out, is part of the contribution that the member makes in their monthly premiums. I think, it's important to mention at this point that in the medical world, it becomes a matter of, the young that subsidize the old, and the healthy that subsidize the unhealthy. And that's important because you actually see the knock-on effects of that later on as populations age, become more unhealthy, and you see the increases in premiums. There are some challenges that are faced even though you have private medical aid cover. And I think the first and probably the most important is that they are very complex products. Even me, having worked at a medical aid company for a very long time, I still struggle to understand a lot of the benefits and a lot of how it's actually put together. And there's this element of it being expensive and premiums increasing annually. And there's a reason for this. There's a reason that premiums increase annually. And the three that stand out is because technology advances all the time. In the healthcare space, 2 years is the lifespan of anything, and then it becomes obsolete. And so because funders are under pressure to fund for the newest and the greatest all the time, it does put a burden on them. A second big contributing factor to the rising costs of healthcare is fraud. And there's great fraudulent activity. if you just Googled, you will see that it costs the system billions of dollars in the States because members and healthcare providers act fraudulently. And the last important factor is that we are an aging population. So our healthcare needs do progress each year. So it does cost the system a lot more now than it did 10 years ago because our conditions have progressed, it has changed, we have gotten older, and we are now presenting with a lot more conditions that we didn't have back then. Co-payments and deductibles are a reality, and they are applied to certain conditions, certain procedures or services that are rendered. And you really only benefit from not having to pay a co-payment if you stick within certain networks that the medical aid identifies. But often we understand that in this space, you have come such a long way with your disease and with the caregivers or the healthcare providers that you're seeing. And so you are comfortable staying with them. And if they're not in that network, you are faced with these co-payments. And having to almost force yourself into this network means that you now have limited choices. So you're not at liberty to choose any longer who you want to because there's that cost offset. And then there's the factor that medical schemes only pay up to the scheme rates. And we know that a lot of the doctors claim 200 to 300% above medical aid rates. So in this space, even a normal visit to the doctor would mean that you are paying out of pocket. So Rare Diseases had sent out a survey towards the end of last year, and we wanted to give some feedback on what you had to say, you as the public. So these are just some of the questions that we had asked. And the first one was, do you understand your medical aid benefits? And you'll see the majority said no or partly. And I think this is very important because we know that the jargon that medical aids use is often very confusing. And the structures, as I mentioned previously, are very complex. Often there are benefits that are made available, but obviously you have to meet certain clinical entry criteria to access those benefits. Some people actually understand their benefits, but don't know how to go about accessing it. And then as I mentioned previously, your healthcare needs progress and become more over time. But when you stay on your plan without upgrading it, you only have access to what you always had. So there's no changes in the benefits that you have access to. And therefore your needs become a lot more and your out-of-pocket expenses become a lot more. And then a concept that everybody grapples with. In fact, there was a little snippet on Carte Blanche recently, and that was just on PMBs and how it's not just members of the public that don't understand PMBs, it's healthcare providers themselves. There was an article that was published by News 24 that also actually asked the same question. And this was just a general public survey that was sent out. And you can see that these were the categories that members struggle to understand. So there was the limits and the sublimits, medication limits and benefits, co-payments, medical savings, and prescribed minimum benefits. So it seems as though the rare diseases population and the population as a whole don't understand almost the same aspects. So just to provide some clarity, obviously this is not as comprehensive as it can be, but your prescribed minimum benefits is a defined set of benefits that is defined by the Council of Medical Schemes, and all medical schemes have to abide by this list. And it's basically the very minimum access that members can get to healthcare in the public sector that private healthcare insurance companies need to pay in for. That's the simplest we can explain it. The risk benefits are the benefits that are covered by the scheme, and those obviously exclude your medical savings accounts. There's medical review, and those are for exceptional cases that don't fit any of the current existing benefits, but where the member feels that they have a real need and really do need something to be funded, they then put together a case, which is then presented to the scheme, and the scheme then makes a decision on whether they will fund it or not. And then ex-gratia is a financial aid, and it also falls within applying for additional benefits. So in an event where a member has to part pay for a treatment, an operation, etc., if they make a case and present it to ex-gratia then takes it upon merit and then decides whether they will fund either wholly or partly the remainder that the member is then faced with. The second thing we wanted to understand was the main concerns with medical aid. And you can see almost the first two, so almost 50% of your membership have said that the condition and or the treatment is not recognized and therefore it's not paid for either in totally or partially. And also the lack of understanding of medical aid options and the benefit structures. And so these are just some of the quotes that we got from the survey, but we understand that in this space, there are a lot of this would happen. There's rare diseases, there's a lot that exist but do not fall on the PMB list, and because of that, there's a lot of technicalities around medical aids, recognizing it as diseases, and therefore they are not, the treatment's not funded, and neither is the treatment, sorry. And then just to see how we could benefit members in reducing the shortfalls that they face monthly. And the majority of the members fit within this 1,000 to 10,000 category. And it's very difficult to speak to this because we don't understand what the contributing factors are towards this. But the assumption is that there is some proportion of the co-payments that we could potentially eliminate from members if we were to understand what benefits they have access to and apply for it, if we could potentially retrospectively review some of the claims that force them to pay out of pocket and see if we can get them reprocessed and repaid from the right benefit. But what was very alarming for us is these members who actually face co-payments on a monthly basis of up to 50,000 Rand. It's shocking, and I can't think, other than possibly mobility aids, what could be that massively contributing towards out-of-pocket expenses. So we're very interested in unpacking those once we get into the work and just see where can we take some of this burden off the members. And then we just liked to know if your membership would benefit from having us there. And we're really, really grateful that the majority have actually said yes. So it feels like there's a place for us. It feels like we could be of value to a subset of your members at least. And we really are looking forward to this journey and trying to alleviate some of this financial burden that has been facing, your membership has been facing. So this slide just almost wraps everything up. And it speaks to our earlier point of not being brokers. We liaise with all medical schemes. We have got contacts with the administrators that administer many of these medical schemes on this list. And to Kelly's earlier point, there would be some teething problems because we have not dealt with every medical scheme there is, and we'd obviously have to go through the process as and when we get there. But I think we're very confident and we know that we could make this difference. So this is just to show the services that we are offering. And Kelly, this is on your brochure, right?
Correct.
Yeah. Okay. So there are two packages that we are offering. One is a very simple claim submissions and follow-up package. And then there's a comprehensive one, which looks at almost everything that you could potentially need to do with a medical aid, from chronic applications, your PMB benefits, ex-gratia, Section 21, etc. So we are here to assist with any medical aid needs that you might have.
Thanks very much, Anissa. Jerome, I think you might be able to speak now. Do you want to try?
Can anybody hear me?
It's so faint. It's really, really bad.
Okay, I'm going to try again with my headsets. Okay, can anybody hear me now?
It's still quite faint, but we can vaguely hear you.
Okay, sorry about that. And Anissa, thank you for carrying on with the presentation.
No problem.
Okay, so I think
Okay.
Anissa really covered everything that would have been said from my side. So Kelly, back to you, and then I think we can open it up for Q&A.
Okay, perfect. So I just wanted to add that I see some questions are coming through. If anyone is wanting to ask a question, you can do so via the Q&A section or also in the chat section. And then if you want to ask it anonymously, obviously the chat section might not be the best place to do it, but we will answer them now. So I just also wanted to just give some context as from a rare diseases South Africa point of view on what the benefits of this program will be. So obviously there's certain elements we've realized that the rare disease landscape in South Africa is changing significantly. Obviously from a state sector point of view, as we're rolling ahead towards NHI, our focus has had to shift quite significantly to fulfill more of a societal responsibility in terms of making sure that we're inputting correctly into legislation and policy review and development. So as a result of that, we have had to look at dynamic ways of putting programs like this together. So I think that this is probably going to be one of the first offerings that Rare Diseases has ever done that's actually going to come as a cost to the patient. Up until this point, everything we've done has been relatively free of charge. We don't charge membership fees to our patients, as you may know. We try and assist wherever, because we know, and I know this from personal experience as well, is that very, very often our families are financially strained, and we didn't agree in charging a premium. But in this particular case, this is a subscription service, and the reason for that is that one, we do believe that we can reduce your monthly shortfalls, but two, for us to be able to put this process together correctly and appropriately, where you can get the benefits and the correct support that is necessary, and make sure that we have the best resources in place to be able to assist with all of these things, that obviously comes at a cost. And because of the fact that it is only benefiting a certain amount of patients, meaning the patients that actually make use of the service, from a mandate point of view, it wouldn't have been fair for us to take a significant amount of our funding to set aside for only a percentage of our patients. So that is why we are having to charge the service as a subscription base. But we've really negotiated, we've made sure that we can try get it to you as family, well, as individuals, as members, as cost effectively as possible. There are ad hoc services for anyone that doesn't want to sign up for the monthly membership, which is what we recommend, because we know that you can have a lot of the same issues happening over and over again, but there's also just a lot of dynamics when you're dealing with a condition long term. It's not like our diseases go away. You're generally going to be dealing with them for life, and therefore we feel that to sign up for a monthly service is the better option, because at least then you've got ongoing support. It doesn't come in trying to resolve one query and then leave. Just a little bit also, it also frees us up a little bit more to assist more with the Section 21 application. So from a medical scheme point of view, many of us know that a lot of our drugs are brought into the country on a named patient basis. It's not like there's a desire or a need to bring them in mass markets, because we're treating such a few people in the population. Sometimes we only have one patient on a specific drug. So when it comes through Section 21, we also have quite a lot of challenges. That is a whole process on its own. And Section 21s essentially are excluded from medical aid because of the fact that they're not registered products. So there's a lot of discussion that needs to go around that. And we have a lot of work to do, from bringing it in from a Medical Controls Council, who's now known as SAHPRA, point of view. So having an appropriate team in place to assist with the day-to-day case management frees up our time to make sure that there are actually drugs available in South Africa that our patients need, to be able to make sure that they can access the appropriate healthcare that they need. For us, it's an absolute travesty that any patient is not able to access the treatment simply because of the fact that we live in South Africa. So that is one of the areas that we really are wanting to address. So we appreciate everyone understanding. We really do appreciate everybody understanding on this. And absolutely, we're looking forward to making this program as successful as we possibly can. And like Anissa said, hopefully we can reduce the monthly shortfalls that you guys are currently funding. We're hoping it's a reduction in stress levels, increased level of understanding in terms of your benefits. I think educated patients are always healthier patients. And generally speaking as well, just reducing the time element. Time is something that not many of us have. And you want to spend your time wisely. You don't want to necessarily be phoning a call center repeatedly. So hoping that this benefit really, this comes along and benefits everybody. So I'm going to go through to the Q&As. So the first question is, some of the costs, and this is aimed at Anissa, some of the costs relate to both registered and unregistered high-cost drugs, which medical aids may not fund, or potentially only partially fund. Anissa, do you have any comments with that?
Yes, and I think it's something that I should have said during the presentation. As much as we are trying to help, sorry, there's a background noise. We have to always understand that scheme benefit rules will always apply. So we're not jibboing the system and we're not trying to make gaps. We are just trying to follow the process as proficiently and as efficiently as possible, and obviously navigating benefits. So where a scheme does not fund, that is a decision that they've made. We obviously will try and pursue through putting together motivations and presenting it to the medical review team in the hopes that an exception would be made. But we will always respect that rules will always be in place and those cannot be bypassed.
Absolutely, and I think it's also important to remember that we understand that the schemes, in order for them to survive, need to have rules in place. And I think all of us as educated consumers need to understand that there's always two sides to, there's always three sides to the story. But in this case, very, very often, as Anissa said earlier, the schemes are actually set up, the healthy and the young essentially end up subsidizing the old and the sick. And realistically speaking, if we funded treatments ad lib and it was just a free-for-all, schemes wouldn't actually be viable, and our premiums would be priced out of the market. None of us would be able to afford them, and essentially speaking, there'd be no funds available to actually get any benefits. So we need to obviously respect the fact that the scheme rules are in place for a reason, but a lot of the time the schemes haven't considered all possibilities, in the sense that, particularly dealing with a lot of the rare conditions, is that the disease entity isn't known to the scheme, and that's where these sorts of services really can add value, is because we can collate the appropriate information and really ensure that the motivation that is submitted is really painting the big picture, which often doesn't happen, and particularly because of the fact that a lot of the healthcare professionals are also not necessarily aware of trying to navigate the system. We do have another question. Does Navicare also assist with gap cover submissions, motivations if the patient has the benefits, and in the case of unavoidable shortfalls with their medical aid scheme?
Hi, can you hear me now?
Still, it's really, really faint, Jerome. Sorry, I'm not sure why.
No, so gap cover is not one of our product offering, but give us a bit of time. Let us get up to speed with the medical aids. And once we have that down to a fine art, we definitely will consider picking up on the gap cover.
Right, we've got another question. What is your monthly subscription fee? So there are two offerings. The first one is, and I stand to have it in front of me. So the first one, sorry, and I'm just not looking at it. The first one is the basic. It is the basic plan, which handles, let me actually just move along to that slide, because I think that will help. If you guys can just give me 1 second. Right, so obviously I can't find it. I'm going to try share the screen and see if I can do that. Just give me 1 sec. There we go. So sorry, this is going to be quite a, it's not in a JPEG, so I can't pull it into a PDF, I mean a PowerPoint. But these are the two. Basic Assist is 180 Rand a month, and that'll handle generalized claims and follow-ups. So if you are one of those patients who is sitting in a position where a lot of your initial groundwork has been done, your treatment has essentially been approved, you're accessing your chronic benefits, but you're just needing assistance in making sure that all your claims, etc., are paid appropriately, that would be the option for you. If you are a patient who requires benefit applications and renewals, special motivations and applications, etc., then obviously Premium Assist, which is at a cost of 270 Rand a month, will be a better option for you. I must also just, there are some ad hoc services as well for those members, like I said earlier, who are obviously not members of rare diseases, or who are also just needing assistance on a once-off basis to be able to access those services. But I think one of the critical things, it'll also assist us in making sure that from a PMB point of view, that you are relatively well monitored. I think one of the very critical things that we found as a patient advocacy group is very often patients are not necessarily doing all the necessary testing, etc., to monitor their disease progression. And so as an example, you get diagnosed with a condition, you go for that initial tests and scans, etc., that need to be done to get a diagnosis, which then happens, and someone starts you on treatments, and then you almost stop going back to check up, etc. You just continue getting the same script over and over again, and there's no changes. One of the downsides to that is very often we find that patients are actually deteriorating, or they're not receiving optimal care. So this will allow us as a patient advocacy group to also assist in making sure that patients have done what is necessary according to their PMB benefits to make sure that they are being appropriately treated. So as an example, a muscular condition, something like going for regular cardio appointments, cardiology appointments, etc., that is actually done. So I know from speaking to patients that often they'll say, no, I can't go to the cardiologist, my heart's fine. I went 3 years ago, there's nothing wrong with my heart, but it's so expensive every time I go. We want to make sure that all those benefits are actually being appropriately covered, so that we can also ensure that the patients are receiving optimal health care. Right, let me go back to the Q&A and let me see. So there we go, I've addressed the monthly subscription fee. We also had another question. I qualify for PMB, but my medical aid doesn't cover standard dental, optometry, or doctor's appointments. So again, I think that comes back to, and I'm not sure, Anissa, if you heard that, because I saw you disappeared for a bit.
Sorry.
That comes back to having a good understanding of what cover you have purchased. And again, that requires a conversation with your broker. Brokers are critically important. Anybody who's ever signed up for medical aid, I'm hoping has gone through a broker who's advised them accordingly. We have another question. Would you handle difficulties arising from admissions? In my case, the doctor wanted me to be admitted to hospital. Saw her on the Thursday, Friday morning, applied to medical aid, and it's almost Thursday and they still haven't approved it. Anissa, do you want to fill in there?
Yes, so we definitely will be able to assist in that aspect. We obviously just need to understand what the holdup is from the medical aid or the reason for the decline. But obviously, if it's a legitimate admission and it's been advised by the doctor, then we just need to understand from the medical aid what's happening. But yes.
Okay, are there any more questions? If there are, is everyone available to put them on now? Okay, we applied for PMB therapy last year and it was denied. Could you assist with this?
Yes, we definitely can assist with PMB. It is a bit complex, I will admit, for me myself, but Jerome understands it a lot better. But yes, again, with everything, with every aspect, it's just understanding what the requirements are, from who, and then the submissions made to the medical aids, and then understanding what's transpired between the two parties and trying to get that sorted out. So definitely we can help with the PMB.
Yeah, I think it's also, it's a very, very interesting, PMBs are a very, very interesting dynamic for anybody. But I also think as a patient, if you have a clearer understanding of why the scheme has declined, and you can understand that there's a reason, there's a valid reason, I think it makes it a lot easier to handle the decline than if you are just of the opinion that they just haven't received the documents, or no one's gotten back to you, etc. That can be quite frustrating. So I think this service will go both ways in making sure that patients are also appropriately educated as to why a treatment has been declined, or what the risks are associated with that, etc. Now we do have, I just want to pop over, I'm seeing some more questions popping through. Okay, so we will be sending out the question is, how can we get hold of us? The email address is assist@rarediseases.co.za. You are also more than welcome. I'm going to show you a quick screen of how it is that you can go register right at the end, but we will be sending out an email to all of the participants of this webinar tomorrow to make sure that you've got the necessary information. To sign up, you can do so on our website. There's a big red button on the right-hand side that says Rare Assist. If you click on there, there is a application form. It does ask you for some medical information. Obviously, it's critical that we have that, such as name, surname, your email address. Please make sure your contact details are correct, your membership number, etc. We can't enter into any correspondence without necessarily having that information, as well as various consents, etc. And once that is up and running, you will then receive an email from us letting you know that your membership is active. The medical aid can see, this is another question, I have diseases, so why can't they allow yearly eye tests and dentistry? That is a question that's come through. There's not much context to the back of that. I'm not sure, Anissa, if you want to comment.
So the dentistry and the eye tests fall within the day-to-day limits. And obviously once your day-to-day limits are exhausted, you no longer have access to it. And obviously in this space, with members having to face co-payments and also paying a lot of out-of-pocket, I'm assuming that the MSA expenditure is also quite exorbitant. And for that reason, they might not have access to additional benefits. But again, it's understanding what scheme the member is on and understanding what benefits that scheme and plan option have available to the member before we can make a conclusive judgment on why they do not have access to dentistry and optometry.
Okay, another question. Why is spinal muscular atrophy not recognized as a PMB when muscular dystrophy is covered as a PMB? SMA is recognized as part of the muscular dystrophy family by the Muscular Dystrophy Foundation. I'll answer this one. There's a second part that Anissa can jump into this question. But just to give you all an idea of how PMBs came about, for those who might not know, it is a coding classification. There is a group of conditions, 270 of them, that have been classified as prescribed minimum benefits via their ICD-10 code. So regardless of where they're categorized from a phenotype point of view, from an ICD-10 classification, they might make it off the list. Now, we do know that the PMB list has not been reviewed for over a decade. This is something that is currently being addressed at the Council for Medical Schemes. There has been a lot of discussion over the years as to who's responsible, whether it's a mandate by the Department of Health or if it's a Council for Medical Schemes issue. Council for Medical Schemes has now undertaken to actually review that list. Again, it's not something that happens overnight. It is a hectic, extensive process. But yes, there is that. However, I also think it's important to mention that you are not only on a medical aid for PMB cover, you also have insured benefits, and that if you can't access something, the idea around PMBs was to ensure that patients had annual access to chronic illness benefits all year round. So what was initially happening before PMB came into place is a patient would have a very expensive condition. I'm going to use diabetes as an example. While they had funds in their medical accounts, they would get treated optimally for their diabetes until, say, June, July, when they ran out of their medical funds. They would then stop all treatments until the following year, January. Now, that's obviously not an ideal, it's not an ideal scenario for any patient, and they actually landed up getting worse. So PMBs were put together to ensure that patients had access to the prescribed minimum level of care all year round, and that it wasn't impacted by your plan type. So regardless if you're on the lowest plan or the highest plan, it made no difference. You would still have access to that chronic care. The second part of this question is we need physio on a weekly basis, and it gets paid from our savings account. So by June, our funds are depleted. I've been battling with this since 2016. My medical aid classes my condition is another genetic disorder. They also say they handle cases individually. No luck. Can you assist?
So to your point about not all conditions being recognized for PMB cover, there are instances where symptoms can be covered as PMB. So understanding what the condition is, what the treatment options are, and then applying for PMB cover for the symptomatic treatment. So we would have to understand which medical aid, which plan type, and then, as Kelly has mentioned earlier, there are additional benefits that schemes do make available depending on what plan type you are. So it's then exploring what other options are available once you've exhausted your savings account, or potentially not even accessing the savings account and having it paid from the correct benefit. So again, it's just understanding your presentation, understanding the medical aid, the benefits, and then trying to make sense of where we can potentially assist in getting the claims paid.
Okay, so that seems to be it from a question point of view. Again, I'm going to show you this screen very, very quickly so that you guys can see exactly what it's looking like on the website. You just give me 1 second. There we go. So that is where you'll find us on the website. If you click on that big Rare Assist button, it'll take you through the various registration forms. And again, we really, really hope that this is a new avenue for us to stress less and make sure that we've accessed our benefits appropriately and that we understand them. I think it will also be a good service for the medical aids, because they will be able to also communicate with, I think if I had to work in a medical aid call center and had to deal with anybody who's dealt with me on the phone, I'd be hysterical when I left for work every day. So I think it also helps to have a sort of a third party to just be able to navigate, you know, the barriers and be able to explain both sides of the story to all parties. So I think that will also help from their point of view. And hopefully at the end of the day, as a community, we land up making sure that whatever expenses are paid to keep us healthy are done so appropriately, and that our patients are treated optimally and access the very best services and care, and that we all land up becoming healthier. So that's ultimately the goal. Thank you everyone for joining us. Anissa, Jerome, thank you so much. We look forward to this new journey. Jerome, sorry we couldn't hear you this evening. I think the woman drowned him out, as we usually do. Yeah, so thank you very, very much to everyone. Please do check in on our website. You will be receiving mails. This webinar will be available on our website as well to be downloaded in future. So if you have somebody that you feel would benefit from listening to this talk, you can download it from our website and you'll be able to access it there. So having said that, thanks to everyone for joining us, and I hope you guys have a great evening.
Thank you.